Discussion on myocardial stunning and hibernation. Myocardial stunning is reversible myocardial dysfunction after ischemia and reperfusion. It is different from myocardial hibernation, in which persistent chronic ischemia causes myocardial dysfunction, which is reversible after revascularization. Mechanism of myocardial stunning is thought to be either due to oxygen-free radicals or calcium overload produced by the ischemia reperfusion sequence. Myocardial stunning is the reason for persistent left ventricular dysfunction for hours or even up to a few days after successful reperfusion in acute myocardial infarction. This can be noted after reperfusion by thrombolysis or percutaneous coronary intervention. Repetitive episodes of stunning secondary to ischemia can lead on to hibernation. Lower myocardial necrosis, as suggested by a lower peak creatinine kinase level, has been shown to be an independent predictor of recovery of ventricular function. Though almost half of the recovery of left ventricular function occurs later, the ejection fraction achieved on third day after myocardial infarction is predictive of survival. Hibernating myocardium is a chronically ischemic myocardium, the function of which improves after successful revascularization. Short of revascularization, presence of hibernating myocardium can be documented by improvement in regional or global function of the left ventricle in response to nitrates, inotropes, and post-extrasystolic potentiation. Nitrates delivered sublingually or as an infusion during a wall motion study, either by echocardiography or by nuclear perfusion imaging, can document improvement in wall motion due to improvement in the circulation. Inotropic stimulation during echocardiography can also document similar improvement in wall motion during low dose stimulation. Post-extrasystolic potentiation is a simpler method as it does not involve any additional measures, only just longer period of imaging. The beat after a ventricular premature beat has natural augmentation of inotropic state of the myocardium due to increased availability of intracellular calcium. The ectopic beat, though it releases calcium, does not utilize it fully. Hence, part of it is available during the post-extrasystolic beat in addition to the regular amount of calcium being released during the index beat. The extra calcium invokes an inotropic response in the hibernating myocardium, which manifests as an improvement in wall motion during echocardiography or perfusion imaging. Myocardial hibernation can be considered as an adaptive response of the myocardium to chronic ischemia to improve survival of the myocytes. As the chronic ischemia progresses, there seems to be a perfusion contraction mismatch which occurs to preserve viability. A non-contracting myocardium needs only less amount of aerobic metabolism to maintain viability. Dobutamine stress echocardiography, myocardial contrast echocardiography, single photon emission computed tomography, and positron emission tomography are the important modalities of assessing myocardial viability and thereby establishing the possibility of hibernating myocardium in the setting of chronic ischemia. You may wish to check out another video on this channel on assessment of myocardial viability. Myocardial contractility recovers significantly in hibernating myocardium after successful revascularization, but the period needed for recovery varies depending on the duration and severity of ischemia which induced the hibernation. In chronic severe hypoperfusion, it may take several weeks for the completion of recovery process. This is because the amount of contractile proteins may have decreased due to the catabolic wasting which occurred during the chronic ischemia. New protein synthesis after successful revascularization takes a longer period.